Implemented policies affect various components of a health system in terms of service delivery, workforce, information, financing, medical products, technologies, leadership and governance. Implemented barriers such as demand and supply side barriers, market, insufficient resources, cultural barriers, imperfect communication, information, education, coordination, leadership, and governance affect the poor and vulnerable groups in developed and developing countries from benefiting from public spending on public health policies and programs. An important factor in socio-economic development of any nation is the extent to which that country is involved in healthcare delivery system. Good health is a vital factor of quality of life as well as prerequisite for achieving socially and economically productive lives of a nation. No government can function effectively without an appropriate healthcare system. Healthcare system is one of the basic institutions that is universal in nature and without which a society cannot survive. The World Health Organization report defines health system as comprising all the organizations, institutions and resources that are devoted to producing health actions. Health actions in this context entails any effort, whether in personal health care, public health services, or through intersectional initiatives, whose primary purpose is to improve health. Healthcare institutions consist of formal and informal organizations, where preventive, social and clinical services are rendered to the members of the society. Each of the institutions has specific aims and objectives, even though they all exist to promote health, to prevent the occurrence of diseases, to bring about a peaceful end for those suffering from terminal disease, and to treat human illness. Most healthcare institutions form an arm of the government. Their social structure follows the same pattern as other government institutions. Healthcare institutions form a large social system, and within this system are other larger subsystems. The systems vary from one country to another and even slightly within the same country. What is health system? This concept will be clear for you. Health system comprises all organizations, institutions and resources that are devoted to producing health actions. Health actions in this context refers to any efforts, whether in personal health care, public health services, or through intersectional initiatives whose primary purpose is to improve health. It is an open system with three components of input, processes, and output. Input required in a healthcare system include finance, physical structure, equipment, personnel, and clients. The process refers to a series of activities that transforms input into a desired product, service, or output. The term output is used to describe the direct result of the interactions of our input and processes in the system. The types of quantities of goods and services produced by an activity, program, or project. The term outcomes refers to the result of the outputs, the effects or impacts. Outcome is basically effects and influences. All these depends on how efficiently the system within the operating environment is administered and how these resources are managed. According to the World Health Organization, it is the approach to medicine that is concerned with the health of the community as a whole. Health policy is basically the decisions, plans, and actions that are undertaken to achieve specific healthcare goals within a society. An explicit health policy can achieve several things. It depicts a vision for the future, which in turn helps to establish targets and points of references for the short and medium term. It outlines the priorities and the expected roles of different groups, and it builds consensus and informs people. In fact, the mission of the health policy is to fulfill society's interest in assuring conditions in which people can be healthy. Three core public health policy functions are the assessment and monitoring of the health of communities and population at risk to identify health problems and priorities. The formulation of public policies designed to solve identified local and national health problems and priorities. To assure that all populations have access to appropriate and cost-effective care, including health promotions and disease prevention services, and evaluation of the effectiveness of that care. To be more precise, health policy means more than a national law or intervention. Operational policies are the rules, regulations, guidelines, and administrative norms that governments use to translate national laws and policies into programs and services. Health policies can be defined as the decisions, plans, and actions that are undertaken to achieve specific healthcare goals in a society. Health policy can also support program activities such as elimination of inequalities in healthcare delivery services or mobilization of community health workers. Policy implementation. What is the meaning of policy implementation? It is the administration of law in which various actors, organizations, state, local authorities, procedures, and techniques work together to put adopted policies into effect into an effort to attain policy or program goals. For our purpose, implementation can be conceptualized as a process, output, and outcome. It is viewed as a series of decisions and actions directed towards putting a prior authoritative federal legislative decisions into effect by the state or local authorities or organizations. Implementation can be defined in terms of the extent to which programmatic goals are supported, such as the level of expenditures committed to a program or the number of violations issued for failure to comply with the implementation directive. Policy implementation can be conceptualized as some measurable change in the large problem that was addressed by the program, public law, or judicial decisions. Implementation can be considered rightly that many changes attempts fail because no distinction is made between theories of change, which means that what causes change, and theories of changing, which means that how to influence those causes. It is very important to point out that policy change goes hand in hand with policy implementation. It is the carrying out of a basic policy decision, usually incorporated in a statute, but which can also take the form of important executive orders or court decision. It is difficult to say which factors or conditions facilitate successful implementation, since so much depends on the political, economic, and social context. For instance, local factors such as size, institutional complexity matter for policy response. This has not stopped from trying to come up with the most important factor for certain policy areas. To take the example of education policy, successful implementation have been evident in schools where there is coherence, stability, peer support, training, and engagement. Successful system reforms means that a small number of powerful actors are interacting to produce substantial impact. Successful implementation implies that agencies comply with the directives of the status. Agencies are held accountable for reaching specific indicators of success, goals, local goals are achieved, or there is an improvement in the political climate around the program. Local capacity and will matter for policy success. Adequate resources and clear goals are important too. The implementation process is characterized by a multi-stage developmental character. Even if policy implementation appears to be successful, pointed to be noted that there is no guarantee that success will last. In terms of the change process in schools, there has been strong adoption and implementation, but not strong institutionalization. Both local school development, which engage the teachers and students, and quality of surrounding infrastructure are key for lasting success. But successful examples of policy change are still in the minority. Changing policies is not sufficient if there is no reculturing of classrooms. A number of conditions need to be satisfied to enhance the change of successful and sustainable implementation. Though these conditions vary across systems, are top-down and bottom-up approaches, a widely used concept in the policy implementation. The two approaches vary in a number of areas, such as the role of actors and their relationships, and the type of policies they can be applied to. Top-down theorists see the policy designers as the central actors and concentrate their attention on factors that can be manipulated at the central level. The most detailed top-down approach was presented by the Sabatier and Mismanin, who identified a number of legal and political variables and then synthesized them into six conditions needed for effective implementation, ranging from clear objectives, causal theory, legal structure of the implementation process, committed officials, supportive interests, group 2, no undermining of changing socio-economic conditions. In terms of policy areas, top-downers usually prioritize clear possible. What are the strengths and weaknesses of this approach? One strength of the top-down approach is that it seeks to develop generalizable policy advice and come up with consistent, recognizable patterns in behavior across different policy areas. But top-down approaches are criticized for only taking statutory languages as a starting point and do not consider the significance of previous actions. The approach may be said to consider implementation as an administrative process and ignores or eliminates political aspects. Bottom-up approach emphasizes target groups and service deliveries. Policy is made at the local level. The top-up approach developed by Porter identifies the networks of actors who are involved in service delivery in one or more local areas and asks them about their goals, strategies, activities, and contacts. It uses the contacts in order to develop networking techniques to identify the local, regional, and national actors involved in the planning, financing, and execution of the relevant governmental and non-governmental programs. This provides a mechanism for moving from local actors and decision makers, such as teachers or doctors, up to the top policy makers in both the public and private sector. Among the benefits of the top bottom-up approaches is its focus on currently located actors who devise and implement government programs. Contextual factors within the implementing environment are important. Actors and their goals, strategies, and activities need to be understood in order to comprehend implementation. Bottom-up approaches do not present prescriptive advice, but rather describe what factors have caused difficulty in reaching stated goals. It is significant that strategies are flexible so that they can adapt to local difficulties and contextual factors. Bottom-up approaches have been criticized on two counts. First, policy control should be exercised by actors whose power derives from their accountability to voters through their elected representatives. But the authority of the local service delivers does not derive from this. Secondly, this approach tends to be overemphasizes the level of local autonomy. There are many kinds of healthcare regulations which include facilities, cost, quality, and pharmaceuticals. Governments attempt to influence healthcare delivery indirectly by providing financial support for certain activities and directly attempt to move resources around in the health industry. One such attempt is through the regulation of healthcare facilities and more comprehensive planning for the health needs of communities. Another regulatory device is the control of cost in terms of making majority of expenses paid by a third party. The regulations of healthcare quality is another area of intervention in health policy implementation. The major public instrument used for regulatory the quality of medical care are the professional standards review organizations. These organizations are designed in part to monitor cost of services provided to Medicare patients. Government should develop institutional capacities to ensure that appropriate uptake and integration of policies into existing activities. Integration of policy into private sector and community programs such as public-private partnership and community-based distribution network. These health policies can also support other program activities, which include elimination of health inequities or maldistribution of medical products or vaccines through increased mobilization and distribution of services, such as modern contraceptives and vaccines by common health workers. Conduct of media campaigns for improved public education and information on prevention, care and treatments. Demand creation for services to marginalized populations and for population mobilization for health activities, programs or projects. Integration of policy can also be into sectors that contribute to health, education, agriculture, and roads. For efficient services to emerge from health policy implementation, accountability, and transparent mechanisms should be well established so that civil society can monitor the implementation process in terms of service coverage and quality, population coverage and equity, healthy behaviors by increased number of people. What are the barriers to effective health policy implementation? Economics is the most commonly cited barriers to access the healthcare. Majority of the medical care is still paid for privately. Those who lack the income or insurance to pay for medical care may not have that medical care. Many who are poor but not sufficiently poor to qualify are not eligible to receive Medicaid benefits. Many people do not have health insurance. The elderly people poor who have access to Medicare as a result of their age must still pay for parts of their insurance at a rate that may deter some taking full advantage of healthcare program, even having insurance as well as not having it can present troubles. The principal problem is that it can minimize mobility in the economy. If a person has a job that provides health benefits, it is difficult for him to leave that job for one that may be better in other respects but does not offer insurance. If the new job does provide insurance, it may not cover pre-existing conditions. Then moving between jobs may be possible. Demand is influenced by factors that determine whether an individual identifies illness and is willing and able to seek appropriate health care. The model levels to a demand for health care of a given quality that is determined by individual and community factors, as well as the price of medical care and other similar goods. Individual factors include age, gender, and income. Demand barriers to utilization of healthcare include information on healthcare choices. This provide lack of knowledge of the providers. Education, low ability to assimilate health choices and negotiate access to appropriate providers. Education and knowledge about the characteristics of and need for medical treatment. Information and education are related to failures either in the form of knowledge of healthcare choices or in the ability to utilize this information in an effective way. Indirect consumer cost barriers. These are the result partially of income distribution and partially of lack of mechanism to spread risk across the population. Education and knowledge about the characteristics of and need for medical treatment. Information and education are related to the failures either in the form of knowledge of healthcare choices or in the ability to utilize this information in an effective way. Indirect consumer cost barriers are the result partially of income distribution and partially of lack of mechanisms to spread risk across the population or across time so that individual can pay for care when they can afford it rather than at the time of illness. The effect of household choices in preventing access to care to certain members is likely to be mainly the result of intra-household inequity. Distance cost. Long and slow travel to facilities. Distances to facilities imposes a considerable cost on individuals and this may reduce demand. Opportunity cost, need for patient and carrier to stop working for long periods in order to seek care. Household preferences as a symmetric control over household resources. Community and cultural preferences attitudes and norms, reluctance to seek health care for women outside home, community resistance to using modern medical care to assist pregnancy. For example, cultural barriers such as cultural norms is often raised still further when men provide services and has often offered as one reason why Asian women living in Western countries often make little use of healthcare services. Such restrictions may also interact with other barriers. Community factors may include cultural and religious influences and other social factors that affect individual preferences. Community barriers may also be related to information failure, where they arise as a consequence of a lack of information about what constitutes medical provision and how patients will be treated once at a facility. For example, information might be used to reassure female patients that they will be treated by a female doctor. Input prices and input availability. Substitute products and services. Patients seek treatment through providers that are inappropriate for their condition, such as drug sellers. Price is a complex variable and includes direct price and distance cost, opportunity cost of treatment, since treatment can be time consuming, and any informal payments made to the facility for commodities or to staff. Quality of staff may be absent because of the price of the wages and staff not attracted to the area. Knowledge of technology of treatments, inability to treat disease with given technology, management efficiency, poor quality of management training, lack of management systems. The determinants of demand may generate barriers to utilization of healthcare services. Education and information assist to assimilate health messages and are important in determining demand. Barriers may also interact with other demand barriers and act as important determinant of the willingness to travel long distances to obtain treatment. Increasing demand is far more complex than simply the provision of health education, advice, or information, but is also strongly related to the relative positions and education are family members. Demand barriers present in low and middle income countries and even richer countries can be found among vulnerable groups. Housing demand is more complex than simply the provision of health education, advice, or information, but is also strongly related to the relative position and education are family members. Demand barriers present in low and middle income countries and even richer countries can be found among vulnerable groups. When it comes to supply, the provision of healthcare is a monopoly. Entry into the marketplace for potential suppliers is limited by licensing requirements and further controlled by the professions themselves, which limits the number of places available in medical schools. One possible means for promoting competition is to break down the monopoly held by the medical professions by giving nurse and the paraprofessionals a greater opportunity to practice. The medical profession rather vigorously resists such changes. Hospitals do compete increasingly for patients, and with that competition has come some greater attention to the quality of care. Price and quality of drugs and other consumables and weak cold chain may cause scarcity of supplies. Supply barriers affect patients in obtaining treatments, especially for the poor and other vulnerable groups. Medical care costs are problem for government as well as for private citizens. A number of factors have been identified as causing at least part of the increase in medical care cost. For hospitals, one factor has been a rapid increase in the cost of supplies and equipment. Physicians' costs also have been rising, not as rapidly as hospital costs. In addition to general pressures of inflation in the economy as a whole, increases in equipment and supply cost, increased insurance paperwork, the increasing cost of medical malpractice insurance, and the practice of defensive medicine to protect against malpractice suits by ordering every possible diagnostic procedure have all produced increases in doctors' fees. Citizens and government must be concerned with quality of medical care being provided. Citizens' obvious expressions of concern about quality have been the increased number of malpractice suits and complaints against physicians and hospitals. Government concerns about quality extends from the Journal Social Responsibility for regulating the safety and effectiveness of medicine and medical devices on the market to the quality of care provided to Medicare and Medicaid patients to perhaps a more physical concerns with the efficacy of modern medical care as a remedy for the health problems. Medical care is still a difficult product for which to judge quality. Little information on quality of medical care is available to the consumer. About the quality of services, consumer about the quality of services provided by individual physicians or hospitals. The public sector has been intervening to try to make more information available, but it is still difficult for the average consumer to make choices. Medical care is mal distributed. The areas and persons with the greatest needs for healthcare are not the areas and persons with the greater access to care. Hospitals, clinics, doctors, dentists, and other healthcare professionals are disproportionately located in well-to-do urban and suburban areas, as the highest fees can be generated there. The residents of these areas have better access to care than do the poor and residents of rural areas. This phenomenon is particularly true for access to specialized institutions and personnel, but it is also true to a lesser extent for general practitioners and basic care institutions. Medical care is distributed on the basis of ability to pay rather than on need. The limited access pattern contributes to the poor health and shorter life expectancy of those who are poor or live in rural communities. Unequal access is significant barrier to healthcare. Gaining equality in medical care is difficult to the poor. Geography distantly plays a significant dual role in defining access to medical care. Urban areas are generally better served with doctors and hospitals that rural areas are. Medical services would be even more pronounced if the areas of specialization of physicians and the standards and equipments of the hospitals are considered. High quality medical care may not be available, even for someone who can afford it, without a substantial investment in travel. The relatively high rate of infant mortality in most low and middle income countries is often taken as an indicator of poor access to medical care. Overspecialization contributes to high cost of medical care, as specialists charge more and use hospitals more than do general practitioners. Family doctors constitute a small proportion of community physicians. Cardiologists, pediatricians, urologists, and other specialists are the dominant figures in the medical professions. Serious consequences from the predominance of specialists may help to account for the rather poor performance on measures of infant mortality and life expectancy relative to those of other developed nations, as these measures are more sensitive to high quality routine care than to sophisticated exceptional procedures. Another problem to healthcare is the financial burden imposed on many individuals and families by its high cost. The gaps in public and private health insurance are wide enough to let millions fall into financial disaster. Unintended consequences are major concerns as health education policy contributes to the over-specialization of physicians, and recent changes in that policy have not yet shown an effect. Public policy, again particularly Medicare and Medicaid, contributes substantially to the cost of escalation in healthcare. As healthcare policy reduces the financial burden on specific individuals, it increases on specific individuals and increases on the society as a whole. The important problem in healthcare, shared by many nations, is its soaring cost to society. The chief causes of cost escalation are growing numbers of elderly, over-specialization, maldistribution, modern medical technology, federal tax policies, and the public exaggerated expectations of medical sciences. There are substantial problems with healthcare policies. Many differences in quality and access to care still remain among various groups. Medicare and Medicaid have contributed to healthcare is inflated costs and have no challenged structural problems in its diversity. the fundamental obligations of governments at federal, state, and local authorities. The national healthcare system should be developed to support in a coordinated manner a three-tier systems of healthcare. Essential features of the system should be its comprehensive nature, multi-sectoral inputs, community involvement and collaboration with non-governmental providers of healthcare. The goal of health policy should be based on primary healthcare, that is promotional based, protective, preventive, restorative and rehabilitative to every citizen of the country within the available resources, so that individuals and communities are assured of productivity, social well-being and improvement of living standards.